Let me ask you something direct. When was the last time you had a full heart checkup? Not a routine blood pressure reading, not a standard cholesterol panel. A real, comprehensive evaluation of how your heart and arteries are actually functioning right now. If you are like most Americans over 50, your answer is probably something like, well, my doctor checks my cholesterol every year, and my blood pressure looks fine. And I want to be honest with you about something. That is not a heart evaluation. That is a snapshot of two numbers. And those two numbers, as important as they are, miss the 5 most critical pieces of information that would actually tell you and your doctor whether your heart is quietly heading toward a problem. Here is what concerns me most in my practice. Heart attacks and strokes in adults over 50 very rarely come without warning. They come after years of silent buildup. Buildup that standard office tests simply do not detect. And the tests that do detect it, the tests that could give you and your doctor a 5, 10, even 15-year head start on preventing a cardiovascular event, are almost never ordered in a routine appointment. Not because your doctor does not care, but because the standard of care for a routine physical does not require them. And what does not get required very often does not get done. Today I am going to walk you through exactly 5 of those tests. What each one measures, why it matters specifically after 50, what the results mean, and most importantly, how to have a conversation with your doctor that gets these tests ordered for you. My name is Dr. Marcus Reed. I have spent over 2 decades in internal medicine focused on adults over 50. And cardiovascular prevention is something I consider the single highest leverage area of health in this age group. Because the window where intervention makes the biggest difference is not after something happens. It is right now, before it does. Before we go any further, drop your name and where you are watching from in the comments. I read every single one, and I genuinely want to know who I am speaking to today. Before I give you the 5 tests, I need you to understand why the standard tests your doctor already runs are incomplete. Because without this context, what I am about to share will not make full sense. A standard annual physical for an adult over 50 typically includes a basic metabolic panel, a lipid panel checking total cholesterol, LDL, HDL, and triglycerides, a blood pressure reading, and sometimes a fasting blood glucose check. These are useful. I am not dismissing them. But here is the fundamental problem with relying on them alone. Every single one of these tests measures what is circulating in your blood at one moment in time. None of them shows you what is happening inside your arterial walls. None of them tells you whether plaque is building up. None of them reveals how stiff your arteries have become. None of them detects electrical abnormalities in your heart rhythm that come and go. None of them shows the actual pumping function of your heart muscle. Think about it this way. Imagine you want to know whether a bridge is structurally safe. You could measure the weight of the trucks crossing it. That is useful information, but it tells you nothing about whether the steel beams inside are corroding, whether micro cracks are forming in the foundation, whether the structure is silently weakening in ways that will not show up until the day something gives way. Your arteries are that bridge, and standard blood tests are the truck weight measurement. The 5 tests I am about to describe are the structural inspection. And after 50, when arterial changes accelerate, when plaque that began accumulating in your 30s and 40s has had 2 or 3 more decades to develop, when your heart's electrical system and pumping capacity have been working non-stop for 5 or 6 decades, the structural inspection is not optional information. It is the information that matters most. Test number 1. Coronary artery calcium score, also called a CAC scan. This is the test I consider most important for adults between 50 and 75 who have never had a cardiac event, and it is the one most commonly missing from standard care. Here is what it does. A coronary artery calcium scan is a specialized low-radiation CT scan of the chest that takes less than 15 minutes and requires no injections, no dye, no stress, and no recovery time. It measures the amount of calcified plaque that has accumulated inside the walls of your coronary arteries, the arteries that supply blood directly to your heart muscle. The result is a single number called your CAC score. 0 means no detectable calcified plaque. 1 to 100 is mild. 100 to 400 is moderate. Above 400 is significant. Above 1,000 is severe. Why does this number matter so much? Because a CAC score of 0 in an adult over 50 with no symptoms is one of the most powerful negative predictors of cardiovascular events available in medicine. A landmark study published in the Journal of the American College of Cardiology found that adults with a CAC score of 0 had a 10-year cardiovascular event risk of less than 1%, even in the presence of traditional risk factors like borderline high cholesterol. On the other side, a high CAC score identifies people who appear low risk by standard measures, but are actually at significant risk. These are the people who pass every routine annual physical and then have a heart attack at 58 that nobody saw coming, because nobody looked inside the arterial walls. This test costs between $75 and $200. It is not always covered by insurance for primary prevention, but it is increasingly being covered as evidence accumulates, and the information it provides cannot be obtained any other way. I had a patient I will call Thomas. Thomas was 56 years old, a successful attorney from Chicago. Fit, non-smoker, moderate drinker, cholesterol slightly elevated but manageable. Blood pressure well controlled on one medication. His cardiologist had told him 2 years prior that his heart health was reasonable for his age. When I ordered a CAC scan as part of a comprehensive prevention evaluation, his score came back at 620. Significant arterial calcification that had been building silently for years, while every standard metric looked acceptable. We immediately intensified his prevention strategy, adjusted his medications, and referred him for further evaluation. Thomas told me afterward that he had walked out of every annual physical for 10 years feeling reassured. The reassurance had been based on incomplete information. The CAC scan provided the complete picture. Ask your doctor specifically for a coronary artery calcium score. If they ask why, tell them your age, your family history, and that you want a baseline structural assessment of your coronary arteries. That is a completely reasonable request, and any internist or cardiologist can order it. Test number 2. Advanced lipid panel, specifically LDL particle number and size. You have had your cholesterol checked. You know your LDL number. But here is what most people do not know. Your LDL number, the one on your standard lab report, does not tell you the most important thing about your LDL. Standard lipid panels measure the total amount of LDL cholesterol in your blood. What they do not measure is how many LDL particles are carrying that cholesterol, or how large or small those particles are. This distinction matters enormously, and here is why. Research has consistently shown that LDL particle number, abbreviated as LDLP, is a stronger predictor of cardiovascular risk than the standard LDL cholesterol number, particularly in adults over 50. A landmark analysis using data from the MESA study found that individuals with high LDL particle numbers had significantly elevated cardiovascular risk, even when their standard LDL cholesterol appeared normal or even low. Small, dense LDL particles are particularly dangerous because they penetrate arterial walls more easily than larger particles, oxidize faster, and trigger the inflammatory response that drives plaque formation. You can have a standard LDL of 110 that looks acceptable and still have a particle profile that is actively accelerating arterial disease. Additionally, an advanced lipid panel typically includes lipoprotein A, abbreviated Lp(a), a genetically determined lipoprotein that is an independent risk factor for heart attack and stroke. Unlike standard LDL, Lp(a) is not meaningfully affected by diet or standard statin therapy. Many people carry significantly elevated Lp(a) levels without knowing it because it is never measured on a standard panel. And elevated Lp(a) carries real cardiovascular risk that requires specific management strategies. Ask your doctor for an advanced lipid panel or NMR lipoprofile specifically. Ask them to include LDL particle number, LDL particle size, and lipoprotein A. This test is widely available, often covered by insurance, and provides cardiovascular risk information that a standard cholesterol panel simply cannot offer. If you are still with me and finding this genuinely valuable, hit that subscribe button right now. Because what I am about to share next, tests 3 and 4, are the ones most connected to the symptoms that many adults over 50 are already experiencing and attributing to something else entirely. Test number 3, carotid intima media thickness, called CIMT. This test directly measures the thickness of the inner 2 layers of your carotid arteries, the large arteries on either side of your neck that supply blood to your brain. Why does this matter for heart health? Because the carotid arteries and the coronary arteries age together. The same disease process that thickens and stiffens carotid walls is happening simultaneously in the arteries feeding your heart. Measuring carotid wall thickness gives you a real-time window into the state of your entire arterial system. The test itself is completely non-invasive. It is an ultrasound, no radiation, no needles, no preparation. A technician places an ultrasound probe on either side of your neck and measures wall thickness with imaging software. It takes approximately 20 to 30 minutes. A study published in the journal Circulation confirmed that carotid intima media thickness is an independent predictor of future heart attack and stroke in adults over 50, adding significant predictive value beyond standard risk calculators. But here is the part I want you to pay close attention to. CIMT is not just a snapshot. It is a measurement that can be repeated over time to show whether your arterial walls are thickening, staying stable, or in response to lifestyle and medical interventions, actually improving. This makes it one of the only tools available that lets you see, in a concrete, measurable way, whether what you are doing is actually working to protect your arteries. I had a patient named Carol, 61 years old, a retired teacher from North Carolina. Carol had been told her cardiovascular risk was moderate based on standard metrics. She exercised 3 times per week, maintained a reasonable diet, and had cholesterol numbers that her doctor described as borderline. When I ordered a CIMT measurement, her carotid wall thickness was in the 85th percentile for her age, meaning her arteries were aging faster than 85% of people her age. This was not visible on any standard test she had ever received. We used that baseline measurement as a starting point for an intensified prevention strategy. 14 months later, her repeat CIMT showed measurable improvement. For Carol, seeing that number move in the right direction was more motivating than any general health advice she had ever received. Because it was her arteries, her numbers, her progress. Ask your doctor or cardiologist about carotid intima media thickness testing. It is available at most major medical centers and many cardiology practices. Type the number 2 in the comments right now if you are still following along. It genuinely helps me understand who is here and getting value from this. Test number 4. Resting and ambulatory electrocardiogram, specifically for atrial fibrillation detection. You may have had an EKG at some point. A standard resting EKG takes about 5 minutes in a doctor's office and records your heart's electrical activity while you sit still. Here is the problem. Atrial fibrillation, the most common serious heart rhythm disorder in adults over 50, is frequently intermittent. It comes and goes, which means a 5-minute resting EKG has a significant chance of capturing your heart during a perfectly normal rhythm window, missing the abnormality entirely. Atrial fibrillation, or AFib, causes the upper chambers of the heart to beat chaotically and out of sync with the lower chambers. During an AFib episode, blood can pool in a small pouch of the left atrium called the left atrial appendage, form clots, and those clots can travel to the brain, causing a stroke. The American Heart Association reports that adults with undetected AFib have a stroke risk 5 times higher than those without it, and studies have estimated that up to 30% of strokes in older adults may be attributable to AFib that was never diagnosed because it was never adequately monitored for. The solution is extended ambulatory monitoring, a small wearable heart monitor, worn for 24 hours, 48 hours, or up to 30 days, records your heart rhythm continuously during normal daily activity, capturing intermittent abnormalities that a 5-minute office EKG would never detect. After 50, I consider extended rhythm monitoring a reasonable preventive screening tool, particularly if you have ever experienced any of the following. Occasional heart palpitations you dismissed as stress or caffeine. Brief episodes of feeling suddenly short of breath without exertion. Moments of unexplained lightheadedness or near fainting. Waking at night with a racing or irregular heartbeat sensation. These are the symptoms that patients consistently tell me they mentioned to their doctor and were told were probably nothing. In some of those patients, extended monitoring found AFib that had been generating stroke risk silently for months or years. Ask your doctor specifically about extended ambulatory EKG monitoring if you have experienced any of these symptoms, even occasionally. The technology is now widely available, the monitors are small and comfortable, and the information they provide is irreplaceable. Test number 5. High-sensitivity C-reactive protein, called HSCRP. This is the test on this list that requires the least explanation technically, but carries some of the most significant implications for cardiovascular risk in adults over 50. C-reactive protein is a protein produced by the liver in response to inflammation anywhere in the body. The high-sensitivity version of this test, HSCRP, measures very low levels of this protein that standard CRP tests miss entirely. Here is why this matters. Cardiovascular research over the past 2 decades has fundamentally shifted our understanding of what drives heart attacks. We used to think atherosclerosis, the buildup of plaque in arteries, was primarily a plumbing problem. Cholesterol accumulates, arteries narrow, blood flow decreases, heart attack occurs. We now know that inflammation is the driver. Plaque does not cause heart attacks simply by narrowing an artery. It causes heart attacks when inflammation destabilizes the plaque, causing it to rupture. A ruptured plaque triggers a clot formation that can completely block an artery in minutes. This is why people with seemingly moderate plaque burden have major cardiac events, while others with more extensive plaque never do. The difference is often inflammatory status, and hsCRP is one of the most accessible measures of that inflammatory status. A landmark study called the Jupiter trial, published in the New England Journal of Medicine, enrolled nearly 18,000 adults with normal LDL cholesterol but elevated hsCRP. The study found that this group, who would be considered low to moderate risk by standard cholesterol-based criteria, had significantly elevated cardiovascular event rates, and that treating the inflammation dramatically reduced those events. In adults over 50, I consider hsCRP an essential component of cardiovascular risk assessment. It is a simple blood test, it is inexpensive, it is widely available, and it provides information about inflammatory cardiovascular risk that no lipid panel captures. An hsCRP below 1.0 milligrams per liter is low risk. Between 1.0 and 3.0 is moderate risk. Above 3.0 is high risk. If your level is elevated, the causes are worth investigating, ranging from diet and lifestyle factors to underlying conditions that are independently manageable. I had a patient named Raymond, 54 years old, a construction business owner from Texas. Standard cholesterol panel completely normal, blood pressure well controlled, no family history of early heart disease. By every standard metric, he was low cardiovascular risk. His hsCRP came back at 4.8, significantly elevated. Further investigation found a combination of factors including dietary inflammation, early metabolic changes, and significant work-related chronic stress that were driving systemic inflammation at a level that his standard labs had completely missed. We addressed each factor systematically. 18 months later, his hsCRP had dropped to 1.1. His other inflammatory markers had normalized. Raymond told me that if we had relied on his standard labs alone, we would never have found what we found, and he would have continued carrying a risk profile that looked clean on paper and wasn't. Type the number 3 in the comments if you have made it this far and are getting real value from this today. Let me give you something practical, because knowing these tests exist is only useful if you can actually get them ordered. Here is exactly how to approach this conversation with your doctor. At your next appointment, say this: I would like to discuss getting a more comprehensive cardiovascular evaluation. I am over 50. And I want to establish a baseline assessment of my arterial health beyond the standard lipid panel. Specifically, I am interested in discussing a coronary artery calcium score, an advanced lipid panel including LDL particle number and lipoprotein A, carotid intima media thickness, extended ambulatory heart rhythm monitoring, and a high-sensitivity C-reactive protein level. You do not need to request all 5 in one appointment. In fact, starting with the 2 most accessible, hsCRP and the advanced lipid panel, is often the most practical first step, since both are simple blood tests that can be added to any standard lab order. The CAC scan and CIMT are imaging studies that may require a referral to cardiology or radiology. The ambulatory heart monitor requires a clinical indication, meaning documented symptoms that justify monitoring. If your doctor is dismissive, you have every right to ask why a specific test is not appropriate for your situation. A good physician will give you a specific clinical reason, and if the reason is simply that it is not standard practice or that your standard numbers look fine, you now have the knowledge to explain why standard numbers tell an incomplete story. You are not being difficult, you are being an informed patient. And informed patients get better care. Let me bring everything together. After 50, heart disease does not develop overnight. It develops over years of silent change inside arterial walls, in inflammatory pathways, in electrical systems, in ways that standard annual physicals are simply not designed to detect. The 5 tests I have described today are not experimental. They are not controversial. They are evidence-based, widely available, and used routinely in comprehensive cardiovascular prevention programs. What they are not is standard, and standard is not the same as sufficient. Here is your complete summary. Test 1. Coronary artery calcium score. A low-radiation CT scan that directly measures calcified plaque in your coronary arteries. The most powerful tool available for detecting silent coronary artery disease before symptoms develop. Test 2. Advanced lipid panel with LDL particle number and lipoprotein A. Reveals the cardiovascular risk hidden inside a normal-looking standard cholesterol result. Test 3. Carotid Intima media thickness. A non-invasive ultrasound that measures arterial wall aging and tracks whether your prevention strategy is actually working. Test 4. Extended ambulatory EKG monitoring. The only reliable way to detect intermittent atrial fibrillation, one of the most common and most stroke-generating rhythm disorders in adults over 50. Test 5. High-sensitivity C-reactive protein. A simple blood test that measures the inflammatory activity driving plaque instability and cardiovascular events independently of cholesterol levels. Print this list. Take it to your next appointment. Ask the questions. You deserve answers that are based on a complete picture of your heart health, not a reassuring snapshot of 2 numbers. I want to ask you directly, has your doctor ever ordered any of these 5 tests for you? Leave your answer in the comments. I read every single one, and your response shapes what I cover in future videos. If this gave you something real today, subscribe to After 50 Health. Share this video with someone you care about who is over 50 and has been told their heart looks fine based on a standard checkup. Because fine based on incomplete information is not the same as fine. Take care of your heart. It has been working for you every single minute of your life. Give it the evaluation it deserves. I am Dr. Marcus Reed. I will see you in the next one. And as always, before acting on anything you heard today, have a conversation with your physician. That is not a disclaimer. That is the most important step in making this information work safely for your specific situation.